Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a left-sided ear infection, and we call that otitis externa. The term otitis externa is an umbrella term given to an infection or inflammation of the outer ear, and the outer ear consists of the ear canal, where we are now, the outermost membrane of the eardrum, so the lateral layer, which is made up of the same skin actually that lines the inner 2/3 of the ear canal, and also the external portion of the ear, so the pinna, which is a satellite dish we have on either side of our heads, which is made up of cartilage. So those three components together, so the pinna, the auditory canal, and the outermost membrane of the eardrum is classified as the outer ear. And this patient suffers from recurrent otitis externa. They have previously been assessed by ENT and a dermatologist. And it's just one of those things, they just develop it now and again. They've been infection-free for a while, I think for about 6 to 9 months. And then suddenly it's flared up again. Now, they are on a repeat prescription of some antibiotic spray, and they do use it on a regular basis to kind of almost as a preventative. A proactive, so to prevent the infection from forming in the first instance. What can sometimes happen is when you're suffering from a bacterial ear infection and you're taking antibiotics, there's always a risk of developing a secondary fungal ear infection as a consequence, and that's because when you have the antibiotics, also they may kill some healthy bacteria. And the skin that lines the ear canal, we have what we call skin flora. So skin flora is like an entire different microorganism ecosystem made up of bacteria and fungi that actually live and reside on the layer of skin. And these are all healthy bacteria and fungi. I'll come back to that in a moment. So what I'm just removing here is some granulation tissue. So it looks a bit fleshy. So I just thought I'll just point that out. So when you have antibiotics, not only can it kill the bacteria that's causing the infection, but it can also sometimes destruct that skin flora and some of the healthy bacteria, which then gives rise and an opportunity for some harmful fungi to colonize on the skin flora and lead to an ear infection. So I have I've written to this patient's GP just to request an ear swab to be taken, just to see whether this is a secondary fungal infection because of the constant use of topical antibiotic spray. So we can see the eardrum in the distance now. Not only did this poor lady have an outer ear infection, so otitis externa, they also had Eustachian tube dysfunction. So the Eustachian tube, the pressure equalizing tube behind the eardrum that connects to the back of the nose, that was blocked at the back of the nose, the area we call the nasopharynx. And when the Eustachian tube is blocked, it prevents air travelling up behind the eardrum to the middle ear, which then creates a negative middle ear pressure, and that causes the eardrum to buckle inwards. It gets sucked in. Very similar to when we're on an aeroplane and we're descending on the plane, the cabin air pressure pushes the eardrum inwards and it gets sucked in and it buckles in. And normally we close our mouth, pinch your nose and blow, and we can force air up our nose, up the Eustachian tube to equalize the middle ear pressure and pop the eardrum back out. We call that the Valsalva maneuver. And in fact, this patient gently performed the Valsalva at the appointment itself, and it did temporarily equalize their middle ear pressure. So I've recommended to them some over-the-counter nasal decongestants. These are steroid-based ones. You're just going to be careful with steroid-based nasal sprays. There's not enough safety data for children under 12, I think. So children 12 and above are typically the ones that can use it. If you overuse the nasal spray, the steroid-based ones, you can develop what we call nasal rebound. And nasal rebound is when your nose actually becomes dependent upon the spray. So if you overuse it, and when you stop using it, you get blocked and you get congested. So you've got to avoid the nasal rebound effect. So I typically recommend patients to use the steroid-based over-the-counter nasal sprays for up to a week. And thereafter, they can perform nasal douching, or they can use saline nasal spray, so saltwater spray, as an alternative. So in fact, behind the eardrum to the right, you'll see some middle ear effusion, so some fluid behind the eardrum. It's got that yellowy appearance. And although the eardrum is still mobile, the patient reports when they swallow, it's a bit of a squelchy sensation. Now that, of course, can be due to all this debris, this macerated dead skin that you can see I'm peeling away. You can see how damp it is underneath there. But it could also be some catarrh, some middle ear fusion behind the eardrum causing that squelchiness. Going back to the fungal infection, so we've got to be careful as well. Now, this patient uses olive oil spray on a regular basis because they suffer from this recurrent and chronic otitis externa, and it causes them psoriasis, so it's very severe itching of the ear canal, and they get very dry skin as a result, and the olive oil helps them to keep the skin hydrated and moisturized and lubricated. However, when you've got a fungal infection, you've got to be careful because the fungi can then almost feed off the olive oil, and it can exponentially cause the fungi to reproduce and significantly worsen their infection. So I've told them to stay away from the olive oil at the meantime. Of course, there is infected anyway, so they can't. We want to, apart from any medication they're prescribed, we want to just keep this ear free from any water, especially because water can exacerbate this. It can create a warm, moist environment for the fungi and bacteria to incubate and further reproduce. Now, although I've removed the blockage and the patient's hearing significantly improves already, I just want to remove as much of this dead layer of skin you can see that's lining the ear canal. It's very damp, macerated, dead skin. And the reason for that, the more I get out, the better opportunity any topical medication that the patient is prescribed can make direct contact with the surface of the skin that lines the ear canal and therefore penetrate deeper into the ear canal itself and fight away this infection. So we're just here at the top of the eardrum. Got to be careful. The inner 2/3 of the ear canal is the bony part of the ear canal, and that can be quite sensitive if you make contact with that. The outer third is made up of cartilage, so cartilage is unlike the bone. It's not rigid, so it is flexible. The skin that lines the cartilage portion is a lot thicker as well. It's about 1 centimetre in thickness. And the skin that lines the ear canal is extremely thin. It's less than 0.1 millimeters in thickness. So we're just working in the attic region, right at the top of the ear canal and eardrums, to the superior quadrant. I'm just trying to peel away some of this skin. Just want to be gentle here. We're going to avoid making contact with the eardrum, of course. So the patient has got a lot of edema. So edema is the medical term for swelling. So their skin cells, the soft tissue on the ear canal, it's inflamed, so it's full of fluid, and that causes edema, swelling. Earlier, I made reference to granulation tissue. So granulation tissue is it's the body's response, a healing response when you've got an infection or trauma. And granulation tissue is essentially a buildup of connective tissue with its own blood supply, and it can give this very fleshy, bumpy, red appearance. They're normally quite moist as well, so they've got some granulation tissue at the roof of the ear canal. So again, you've got this skin layer. You can see how damp and moist it is, so I just want to peel it away as best as I can. And I've just angled the tip of the suction probe just away from the front part of the ear canal. The front part of the ear canal here, in the case of the left ear, so it's on the left-hand side, and on the right, of course, it'd be on the right-hand side. The front part of the ear canal, for me, is the most sensitive part. So the reason why I've angled it away is so the tip of the sucker is not going to embed into the anterior canal wall, and instead it's flared in the opposite direction, so you can almost glide with the side of the fine end against the canal wall, so it's a far more comfortable approach for the patient when you're working in that region of the ear canal. So it's quite tedious work. The patient themselves were very relieved when I was in the ear, because of course, when I'm removing this, I'm almost scratching an itch for them. We've discussed very strict water precautions. The patient already knows because they've been suffering from this for years, so they know to avoid water. So we've asked them to resist the urge of poking in their ears, because that's just going to make it worse. When you scratch an itch, and it's easier said than done, I'm fully aware. We've all had itches and dying need an urge to scratch that itch, but long term it will just make it worse, because in the case here it's just going to scab up more dead skin. The outer layer of skin is a protective layer, so you're going to, by scratching it, you're going to expose it. Of course, you might have some dirt in your fingernail as well, which you're introducing potentially anyway more harmful pathogens into the ear, which we don't want. So more laterally near the outer part of the ear canal, it's very dry, very callous skin. It's you can see here it's very stubborn, very scaly. And we're seeing more and more infections, and I don't know if it's just this time of year, or I'm just personally seeing more and more quite often, and patients with itchy ears as well. So that's becoming, again, in my opinion at least, more of a common ear symptom. So that patients don't necessarily complain of earache or hearing loss or any other typical symptoms like tinnitus or ringing or a buzzing noise in your ears, or vertigo, feeling the room spinning around, or fullness or blockage in the ear. Their symptom is just itchiness. And I have mentioned it in previous videos as well. I'm seeing a high number of patients who are menopausal or perimenopausal, or also suffering from dry skin in the ear. It's well known that patients suffering from the menopause or perimenopause do suffer from dry skin, itchy skin in other parts of the body. And it's purely anecdotal, but I think there's also a link with the dry skin in the ear as well. It's just too much of a coincidence how many patients I see who suffer from the menopause or perimenopause who experience that. So that's the Asian's eardrum. I hope you enjoyed that video, guys. I hope you find it a satisfying one. I know a lot of people enjoy watching those skin peels. Take care, keep well, speak soon, bye.